This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, what's troubling you today, John?
I have this really weird-looking rash thing on my chest. It's kind of below my collarbone, and it's become really itchy over the last day. It's really bad at the moment, actually, and I can't stop scratching it. I mean, I'm trying, but it's too hard, and it looks all kind of scaly and pink. It's pretty weird. And then yesterday morning, after my shower, I noticed there's a lot more of these little spots coming up around it. There'd only been a few up until then. It's definitely getting worse, look.
Okay. Well, that looks like what we call pityriasis rosea. A fancy name for a rash, really. It's common for your age group. Have you been ill at all recently?
I had a bit of a cold for a few days last week. Just a runny nose, sneezing, that kind of thing. I'm fine now, though. About 3 weeks back, I had a really bad nosebleed, and my mum took me to emergency, and it ended up being nothing.
Having a cold right prior to an outbreak is quite common too. The rash usually clears up by itself after a couple of months and rarely reappears, but you'll need to avoid excessive sun and regularly apply generous amounts of moisturiser.
But I have a beach party this weekend at my mate's holiday house. If I can't be out in the sun, then there's no point going. I mean, it's actually his 18th, and he's my best mate. Also, this looks pretty disgusting, and there'll be lots of people there. Isn't there something I can take to help clear it up, or at least stop it from spreading more? Because if that happens, by the weekend, it could cover my whole body.
Oh, that won't happen, I can assure you. But you will have to keep your shirt on for the hottest part of the day. Do you have any allergies, John?
Yeah, I've been allergic to dust mites since I was about 13, I think, so my mum's always cleaning. My skin usually just gets really itchy, and I sneeze like mad. When I was really young, I was allergic to milk, but I'm over that now. The only other thing I have to keep away from is that stuff they put in cheap takeaway food to make it taste nicer. Oh, what's it called? MSG, that's it. That stuff gives me shocking headaches, makes me so tired that I can't do anything for about a day.
How about medical history? Have you ever had any major illnesses or operations?
I had chickenpox when I was a toddler, but I've also had to go to hospital 4 times for things. I've been a skateboarder since I was 6, so I've had a few spills. I broke my left wrist when I was about 8 years old, skating off a quarter pipe. That was a pretty bad one, but I made it over 5 of my friends who were all lined up on the ground. Then later, I'm not sure how old I was, maybe 11, I had one of those really small breaks, like a hairline fracture in my elbow. I also broke 2 of my fingers on my right hand. I had to have them strapped up. That was a pain. And then my last one was last year and was probably the worst because it was so painful. It made the other ones seem like a joke. I had to go into emergency because of some pretty serious grazing along my leg. I came off my board going down a hill on the side of this really rough road. It had dirt all in the wound.
Ooh.
They just washed it out and put bandages all up my leg, but I was in agony.
Well, hopefully that'll be the last of your injuries, so...
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Sarah, the nurse has just informed me that you're here with a scratch on your left eye. Is that correct?
Yes, it's quite painful.
Have you taken any pain relief for it?
Not yet.
OK. While I'm having a look, can you tell me how this happened?
Well, it was my little boy's fingernail, actually. We have a 2-year-old, and I was in the park trying to put his coat on. It happened when he pushed his hand through the sleeve. It's my fault, really, because I should have trimmed them days ago, but every time I try, he rolls his hands into a fist and refuses to let me near them.
He's definitely scratched it. It looks to me to be a minor abrasion, which is good news. I'll be able to give you some lubricating drops to keep it moist and comfortable while it heals.
Are you sure, Doctor? It feels like there's something in there. My vision is different somehow, and my eye seems to be really sensitive to light now. I had to cover it with my hand. Also, while I was in the waiting room, I noticed that it was starting to twitch, like it was trying to get something out. And now, as you can see, the tears are just pouring out.
It may feel larger than it actually is, and the symptoms you describe are quite common even for the most superficial abrasion.
Because a similar thing happened to a friend of mine. It wasn't from her child. I think she was gardening and somehow scratched her eye. She ended up getting an ulcer. I definitely don't want something like that. And that's really worrying because she ended up losing some of her sight. It's been troubling her ever since.
Let me assure you, complications such as the one your friend experienced typically only occur when a very deep abrasion is left untreated. Do you have any history of eyesight impairment?
The funny thing is, I'm nearsighted, so I've been wearing glasses my entire adult life. I'd have had them on today, actually, if I hadn't left them at home on the coffee table. Sometimes I even wear those coloured contact lenses because, as you can probably tell, I have one green eye and one's a greyish blue. I feel a bit juvenile wearing them, but maybe if I'd been wearing those today, I'd have had at least some protection. I've been with the same optometrist for 6 years now, and I go for 6 monthly checkups.
OK. Well, I'll prescribe you some antibiotic eye drops just to ward off any infection while your eye's on the mend. Do you have any allergies or illnesses I should know about?
I know I'm definitely allergic to penicillin and amoxicillin because the last time I had either, I broke out in a terrible case of hives all over my body. It lasted for hours. I didn't have any other symptoms, but the doctors told me to avoid anything in the penicillin family. Also, when I was 22, I went to hospital just for a gastroscopy, nothing serious. And they found that I have an allergy to latex. Their gloves caused a red rash and even some blisters around my neck.
Any medication?
Not at the moment. I was taking something for sciatica, but I haven't had any pain for a while.
Will you be needing a certificate for work?
I'm a full-time homemaker, so no certificates needed for that. The one thing I guess I'll have to hold back from, though, is my aqua aerobics class every Wednesday. Will I have to stay away from the pool, Doctor?
I'd recommend it until your eyes had a chance to fully heal, at least. Now, before I give you any other...
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Sorry to bother you, but I need to report an incident. I've had some liquid, maybe blood, splash into my eye. I've already flushed it with normal saline.
Did this just happen now?
A few minutes ago. I was taking the drapes off after the operation and some fluid just flicked up.
Was the drape heavily soiled in blood?
No, it was fairly clean, actually.
Do you know the status of the patient? Any history of blood-borne viruses?
I'm not too sure. His notes are with him in recovery, but I can check.
You'll have to go straight downstairs to occupational health, where they'll advise and evaluate you and possibly take some blood. Then I'll help you fill in a formal risk assessment. Did anyone see the incident?
Yeah, Julie was helping me at the time.
Then we'll also need her to fill out some details.
Question 26. Now read the question.
Mr. Lee just threw a spoon at me.
A spoon? Why?
He hasn't stopped moaning about me all shift, so I told him to stop. That's when he threw the spoon.
Did it hit you?
No, he's harmless, but that's not the point. He just won't let up. He's fine with other staff, but everything I do seems to be wrong. Apparently, I wrapped his bandage too tight, and he even moaned that I didn't close the curtains properly.
Honestly, it does sound like he's singling you out a little. That's hardly fair.
No, it's not, is it?
I know. Let's ask if you can swap patients with me.
Really? I'd be glad to if you don't mind. I'm sure it's just me he's taken against. I don't want to go back into his room ever again.
I'll give him a few minutes, then I'll go in and try to talk to him.
Question 27. Now read the question.
So, as you all know, we had an incident today. Mr. Parks slipped and he's now undergoing further surgery, this time on his hip. So, having come in for a thyroidectomy, he'll be leaving here with a new hip, not to mention the added anxiety and stress to both him and his family. In the worst case scenario, this could even result in legal action. Now, all this could have been avoided if a minor spillage had been dealt with at once and protocol had been adhered to. I know it's been a very busy day and we're all under pressure, but incidents like this should never occur. I must emphasize, our policy of immediate action upon any spillage of any liquid or substance is in place for a very good reason. To protect our patients as well as ourselves.
Question 28. Now read the question.
I'd like to go over some possible side effects of your atorvastatin medication. This is all explained in the booklet I'll give you, but I want to make sure I answer any queries you may have before you're discharged. But remember, you should contact your doctor or the ward immediately if you have any concerns.
Okay, thank you.
The less serious side effects are commonly mild muscle pain or nausea, occasionally diarrhea. The more serious include severe muscle pain, confusion or memory loss, fever, fatigue, a change in weight, dark-coloured urine, or sometimes an increase or decrease in urination, increased or loss of appetite or thirst, jaundice and possible clay-coloured stools.
That's a lot to take in.
You won't need to remember them all, but it's important to be aware of any changes. Is there anything you'd like to ask?
No, I think I'm okay.
Question 29. Now read the question.
The next patient is Robbie Fisher in room 8.
I just met his mother as I was coming in.
Yeah, she's understandably very worried. OK, he's a 6-year-old boy, very unwell, admitted with hypoxia and respiratory distress secondary to a left lower lobe pneumonia. He was given a fluid bolus at 6 p.m. and was started on oxygen at 2.5 litres. He's on ceftriaxone. At around 12 a.m. you'll need to check that his vitals are stable and unchanged from now and oxygen saturation hasn't dropped. Dr. Stone needs to determine if his blood culture is positive, and if his respiratory status worsens, he'll most likely get you to order a mobile chest x-ray to check for an effusion.
Sure.
Question 30. Now read the question.
So, how do you feel the consultation went?
It was okay, but I don't feel I connected with the patient very well. He didn't seem to want to open up and discuss his condition with me.
I'm glad you picked up on that. It's sometimes difficult for even the most experienced doctor to establish a bond with a patient from the outset.
How could I have handled it differently?
A key aspect of our profession is confidentiality between patient and doctor because it gives a foundation upon which they know they can rely. The patient needs to be assured of this, which in turn helps them relax. Asking questions that are then more open-ended builds on that foundation by allowing the patient to communicate in their own way. This shows that you're there to listen and provide support, and this is paramount for securing any doctor-patient relationship. It comes with a lot of practice.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1. Extract 1, questions 31 to 36. You hear a sports physiotherapist called Chris Maloney giving a presentation in which he describes treating a high jumper with a knee injury. You now have 90 seconds to read questions 31 to 36.
Hello, I'm Chris Maloney, a physiotherapist specialising in sports injuries, and I'd like to present a case study to give you an idea of the sort of work I do. It features a very successful high jumper in her mid-20s who was referred to me with severe pain in her right knee, and that's the leg she takes off from when she jumps. What's more, when she'd stepped up her training in preparation for a big competition, the pain worsened, and she'd been forced to pull out of the event. After that, she'd taken several months off training to rest and get treatment from various therapists. To her dismay, however, not only did the pain continue, it actually got worse, meaning she was unable to do any strength training, let alone jump-specific work. By the time I saw her, she was on the verge of giving up, having lost virtually all belief in her ability. My initial assessment quickly confirmed patellar tendinitis in the affected knee, accompanied by some swelling and significant tenderness over the lower part of the kneecap. This wasn't difficult to diagnose. I also noted that she was slightly overweight for her height and had rather flat feet, but that's not so unusual in high jumpers. Further assessment revealed that the gluteal muscles connecting the hips and thighs were considerably less sturdy than you'd expect in an athlete of this calibre, and both the lateral retinaculum connecting the patella to the femur and the iliotibial band, the ligament running down the outside of the thigh, were tight and tender. As a first stage, I was keen to show I could help by relieving some of the pain, so I worked at loosening her lateral retinaculum to see how much of the tendon pain was due to inflammation and how much came from restriction of normal patellar movement. This manipulation and massage instantly cleared the pain she'd felt while doing a single leg dip exercise, where you stand on one leg and bend the knee. This indicated that her tendon pain was most likely due to patellofemoral joint dysfunction, caused by muscle imbalance and poor biomechanics, and not by an active inflammatory process or partial tear in her patellar tendon. So an MRI scan wasn't needed. The treatment continued along similar lines for some weeks, with loosening of the lateral retinaculum and deep tissue massage of the iliotibial band and other muscles. One option at this point was something called taping. This is a way of reducing pain so that athletes can continue with strength exercises. But it seemed clear from early on that we shouldn't put taping on this patient's patella and tendon until she started jumping again. She was getting pain relief and progress simply from the manual techniques, and taping might have led to problems later on. Athletes often become dependent on tape and other accessories. In other words, instead of aiming for 100% muscle strength and joint position control, they settle for 80% plus artificial support. The patient also had a specially designed program of gym activities. Although she needed to restore power to those muscles affected by inflammation and tenderness, the priority was to get her posture and alignment right. She started by doing double leg squats with her back to a wall in front of a mirror so that she could see whether her feet were arched and if her knees were over her feet. She also did squats while squeezing a ball between her knees. There was light leg press work, followed by single leg stance work, first static, then on wobble boards, and with elastic resistance. She progressed to moving on and off steps, sometimes holding weights, all the time paying close attention to positioning and muscle and joint alignment. The next stage was to liaise with the patient's coach. She began running, jogging for stamina, and then sprint sessions. Work on power was stepped up gradually and included some weightlifting. After some analysis, we also decided to modify her run-up to the high jump bar. By beginning from a wider position and running in with much less of a curve, there was much less of an impact on the ankle, knees and hip, especially in her right jumping leg. Interestingly, the patient reported that remodelling the run-up felt fresh and motivating and helped to reinforce the sense she had of being a reborn athlete. Once the rehabilitation process was complete, she was able to compete without pain and free of any reliance on taping or knee strapping. So, before I go on to the next...
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a clinical psychiatrist called Dr. Anthony Gibbons giving a presentation about the value of individual patients' experiences and stories in medicine. You now have 90 seconds to read questions 37 to 42.
Hello, my name's Anthony Gibbons. I'm a clinical psychiatrist and published author. I'd like to talk about something that's relevant to all medical professionals, the use of narratives in medicine. Let me begin with a case study sent to me by a colleague who shares my interest in the subject. The study featured a 30-year-old man who was hospitalised for severe panic attacks. He was treated with narcoanalysis, but feeling no relief, turned to alcohol and endured years of depression and social isolation. 4 decades later, he was back in the psychiatric system, but for the first time he was prescribed the antidepressant Zoloft. 6 weeks later, he was discharged because the panic attacks and depression had disappeared. He lived a full life until his death 19 years later. If the narrative was striking, it was even more so for its inclusion in a medical journal. Repeatedly, I've been surprised by the impact that even lightly sketched case histories can have on readers. In my first book, I wrote about personality and how it might change on medication. My second was concerned with theories of intimacy. Readers, however, often used the books for a different purpose, identifying depression. Regularly, I received and still receive phone calls, people saying, "My husband's just like X," one figure from a clinical example. Other readers wrote to say that they'd recognised themselves. Seeing that they weren't alone gave them hope. Encouragement is another benefit of case description, familiar to us in an age when everyone's writing their biography. But this isn't to say that stories are a panacea to issues inherent in treating patients, and there can be disadvantages. Consider my experience prescribing Prozac. When certain patients reported feeling better than well after receiving it, I presented these examples first in essays for psychiatrists and then in my book, where I surrounded the narrative material with accounts of research. In time, my loosely supported descriptions led others to do controlled trials that confirmed the phenomenon. But doctors hadn't waited for those controlled trials. In advance, the better-than-well hypothesis had served as a tentative fact. Treating depression, colleagues looked out for personality change, even aimed for it, even though this wasn't my intended outcome. This brings me to my next point. Often, the knowledge that informs clinical decisions emerges when you stand back from it, like an impressionist painting. What initially seems like randomly scattered information begins to come together, and what you see is the bigger picture. That's where the true worth of anecdote lies. Beyond its role as illustration, hypothesis builder, and low-level guidance for practice, storytelling can act as a modest counterbalance to a narrow focus on data. If we rely solely on evidence, we risk moving toward a monoculture, whereby patients and their afflictions become reduced to inanimate objects, a result I'd consider unfortunate, since there are many ways to influence people for the better. It's been my hope that, while we wait for conclusive science, stories will preserve diversity in our theories of mind. My recent reading of outcome trials of antidepressants has strengthened my suspicion that the line between research and storytelling can be fuzzy. In medicine, randomized trials are rarely large enough to provide guidance on their own. Statisticians amalgamate many studies through a technique called meta-analysis. The first step of the process, deciding which data to include, colours the findings. Effectively, the numbers are narrative. Put simply, evidence-based medicine is judgment-based medicine, in which randomised trials are carefully assessed and given their due. I don't think we need to be embarrassed about this. Our substantial formal findings require integration. The danger is in pretending otherwise. I've long felt isolated in embracing the use of narratives in medicine, which is why I warm to the likelihood of narratives being used to inform future medical judgments. It would be unfortunate if medicine moved fully to squeeze the art out of its science by marginalising the narrative. Stories aren't just better at capturing the bigger picture, but the smaller picture too. I'm thinking of the article about the depressed man given the drug Zoloft. The degree of transformation in the patient was just as impressive as the length of observation. No formal research can offer a 40-year lead-in or a 19-year follow-up. Few studies report on both symptoms and social progress. Research reduces information about many people. Narratives retain the texture of life in all its forms. We need storytelling, which is why I'll keep harping on about it until the message gets through.
That is the end of Part C. You now have 2 minutes to check your answers.